Welcome to the American Heart Association Target Blood Pressure Program conference call. My name is James. I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I'd now like to turn the call over to Jerry Henniker. Ms. Henniker, you may begin.
Thank you, James. Welcome, everyone, to today's webinar hosted by the Lake Superior Quality Innovation Network. The quality improvement organizations of Michigan, Minnesota, and Wisconsin have joined together to comprise the Lake Superior Quinn to provide collaboration to improve health care for Medicare consumers and to share best practices and maximize efficiencies. My name is Jerry Henniker, and I will be your facilitator for today's call. In 2015, the American Heart Association and the American Medical Association partnered to launch Target BP to improve blood pressure control and build a healthier nation. This national initiative aims to reduce the number of Americans who have heart attacks and strokes by urging medical practices, health service organizations, and patients to prioritize blood pressure control. Our presenters today are Stephanie Wirth. Stephanie has a 25-year career in the nonprofit industry and has spent the last 6 of those years at the American Heart Association. She served the organization as Regional Health Equity Director and now is Senior Community Health Director and leads the Detroit Markets Community Plan priorities. Stephanie is responsible for translating health aspirations and goals into actionable tactics for all levels of volunteers, fostering understanding of these tactics among staff, and working within the community to help the American Heart Association reach its population health and prevention goals around building a culture of health throughout Southeast Michigan. Suling Chardon is the Senior Community Health Director with the American Heart Association. She has worked in the cardiovascular health area for over 12 years with the American Heart Association and the Minnesota Department of Health. She received her Master's of Public Health and completed her dietetic internship at the University of California, Berkeley. With that, I'll turn it over to Suling and Stephanie.
Thank you, Jerry. Also just wanted to note that our colleague Tim Nikolai in Wisconsin is also on the call, so if anyone has any specific Wisconsin questions, he'll be there at the end, and we'll have his contact information at the end of the presentation. So why are we here talking about blood pressure? Why is it critical to the American Heart Association? We have a goal of improving cardiovascular health of all Americans by 20% by 2020 and decreasing the mortality for cardiovascular disease and stroke by 20% by 2020. So if we're going to reach that goal, we have to look at high blood pressure. We just updated our statistics so you can see in the slide 85.7 million adults have high blood pressure. That's 1 in 3 that have either stage 1 or stage 2 hypertension or are in hypertensive crisis. So why is this important? If we get their blood pressure under control, for every 10-point drop in systolic blood pressure will decrease the risk of heart attack and stroke by 30 to 50%. If we want to reach our 2020 impact goal, we'll have to get people's blood pressure under control. On this slide, you also see the prevalence rates for several populations in the U.S. African Americans have a higher incidence of high blood pressure and are very aware of high blood pressure. Latinos have a lower prevalence but aren't as aware about high blood pressure being a problem. Now let's see how the states within the Lake Superior Quality Innovation Network are doing. So the information we have presented we've gotten from our friends at our state departments of health. So in Michigan, you'll see that the latest numbers that 34.6% of adults report having been told they have high blood pressure. 75.7% of the adults have diagnosed with high blood pressure report taking blood pressure medication. Just want to note that, in Michigan as well as in other states, as the adult population, as the population ages, we see an increase in diagnosed high blood pressure. And then by 2030, heart disease cases in Michigan are projected to rise from 600,000 to 2.9 million, so pretty significant. You'll see the costs associated with heart disease. Heart disease is the leading cause of death in men and in women. In the past 5 years in Michigan, 58,298 women have died of heart disease. This number of women could easily fill the Detroit Tigers the stadium. More than 25% of deaths in Michigan in 2013 were due to cardiovascular disease and stroke. In Minnesota, we're doing a little bit better. We have 27% of adults report having high blood pressure. It's lower than all but 2 states, and this reflects about 1.1 million people. Hypertensive heart disease caused by high blood pressure was listed as an underlying or contributing cause of death for almost 7,000 Minnesotans, representing about 17% of all deaths. In Minnesota, there isn't a huge difference if you compare African Americans and Caucasians with high blood pressure. There's a 1% gap, and it's a smaller gap than the U.S. as a whole. But if we look at education, the gap is much wider. So if we look at individuals with no formal education after high school diploma, have much higher rates of high blood pressure than those with a college degree. So it's 33% versus 20%. We also see that approximately 77% of adults with high blood pressure report taking medications, and 75% of adults in managed care plans who received a diagnosis of hypertension have their blood pressure adequately controlled. So you can see in Minnesota we're doing pretty good. Now in Wisconsin, there are approximately 204,000 individuals with heart disease. Most of the individuals with cardiovascular disease are over the age of 60, and as mentioned earlier, this incidence increases with age. More men than women have cardiovascular disease and heart attacks, so heart attacks are more likely to be fatal for women. Wisconsin has a greater gap of high blood pressure prevalence among populations of color. So with African Americans, there's 39%, Hispanic 35%, American Indian 38%, while the Caucasian population is at 25%. And it's also more prevalent among low-income populations. So if we look at low income, it's at 36%, middle income 27%, and high income 22%. Cardiovascular disease is the leading cause of death in Wisconsin, and if all cardiovascular disease were eliminated through medication, dietary changes, exercise, and not smoking, individual life expectancy would increase nearly 10 years. So it's pretty important of why controlling blood pressure is important. So as most of you know, being in the clinical area, morbidity and mortality due to cardiovascular disease are directly related to blood pressure. When blood pressure is lowered with people in hypertension, there's less vascular damage to the organs, the heart, the brain, the eyes, and the kidneys. We've known since the 60s through the landmark VA1 and VA2 trials that treating high blood pressure with medication reduces the risk for heart attacks, strokes, and death. So on this slide, you can see here in the yellow, we've got some updated numbers here for 2016. So of the over 800 million people with high blood pressure, 45.6% do not have their blood pressure under control. We see a slight improvement from the original numbers on this slide. And this is in spite of the fact that we've had good treatment for over 50 years. Now, if we look at the bottom of the slide, we have 54.4% control, but we have 76.5% being treated. And you can see with the control, we've also had a 0.3% improvement from the original when this slide was put together in 2015. So you can see here from the slide that part of the issue is that with people that 54.4% have their blood pressure in control, but 82.7% know that they have high blood pressure. So there's the gap there. And then we've got 17.3% who are walking around not knowing that they have blood pressure. And I know there's a lot of work being done in Minnesota that Stress Health is involved in, and the health department of increasing the number of undiagnosed hypertensives. So what does this mean? It means we need to get 13.6 million Americans better blood pressure control by 2020 if we're going to reach our 2020 impact goal. It's a big number, but we have 80 million people to work with, and we can do it. And how we're going to do that? By partnering with all of you. So as you can see on this slide, it shows that, even a small 5 millimeter mercury drop in systolic blood pressure shows a nice reduction in heart disease and stroke, and that overall reduction being 7% in overall mortality. So we know that we could save lives if we just move more people to have their blood pressure better managed. So as Jerry mentioned, the Target BP is a collaborative initiative program with the American Medical Association. This kind of came from in 2013. The American Heart Association, the American College of Cardiology, and CDC came together and published a science advisory in 2013, and the paper describes key system process improvements and best practices needed to help clinicians treat their patients with high blood pressure. And we provided a simple treatment algorithm that providers could follow to ensure effective treatment and follow-up for their partners with high blood pressure. Now, Stephanie is going to go over the Target BP program.
Good afternoon. So, what is Target BP? To help address the issue of high blood pressure, we developed Target BP, as Suling said, in 2015 in collaboration with the American Medical Association. So, Target BP is a call to action that's motivating medical practices, practitioners, and health service organizations to prioritize blood pressure control. So currently, we are recruiting primary care providers and healthcare clinics to join us in the fight to provide better treatment for patients with high blood pressure. So as an incentive, we're going to provide recognition for healthcare providers who attain high levels of blood pressure control in their patient populations, particularly those who achieve 70 or 80% or higher control. We'll also recognize those sites that have improved their control rates by 10% or more. So key to the program is providing tools and resources for your clinical staff and patients to help improve your patient populations. We've partnered again with the American Medical Association to develop resources that can help you with the implementation of this program. We have a robust website that includes podcasts, videos, one-page handouts, checklists that you can follow, as well as patient education resources. And we're also going to be offering a series of webinars to demonstrate how to implement system changes in your clinic to help improve your high blood pressure treatment. So there are 3 major components to Target BP. There is the Target BP Recognition Program, which is recognizing physician practices and health systems working to improve blood pressure control rates and reduce the number of Americans who have heart attacks or strokes. There is the Physician Support component, which is supporting physician practices and health systems to attain and sustain blood pressure control rates of 70% or higher among the patients they serve. And then there's patient support, and that includes providing tools and resources to help patients reduce their risk of heart attack or stroke by self-managing their blood pressure at home and in partnership with their healthcare providers. Next slide. So who's our target audience for Target BP? That is primary care systems. So this is a program for the outpatient setting and not for hospitals. We're also targeting government agencies that provide primary care, like local health department clinics. This is where you can assist us in helping to identify and open the door to these settings. Why would a clinic want to participate? We know what medicines work, but systems aren't in place to drive control rates, and control is what we're after. Target BP will give them the tools and training to implement systems to help them better address blood pressure control in their clinics. Algorithm and systems approach described in our treatment algorithm has been shown to increase control rates within a clinical setting. Implementation sites will receive recognition from the American Heart Association, and that recognition is highly valued. And this will help meet required performance metrics that clinicians are being asked to submit for reimbursement. And finally, ultimately, what this really means is improved health and care of your patients. You can find more information overall on Target BP at our website, targetbp.org as well. So I'll give you a quick overview of the recognition program for Target BP. And the recognition program essentially celebrates physician practices and health systems for achieving the control that we're talking about at or above 70% rates within your patient population. So these achievements will ultimately lead to a reduction in the number of Americans who suffer heart attacks and stroke. So we recognize participation in the program, we recognize improvement in blood pressure control, and we recognize achievement of a designated blood pressure control rate and the sustainability of those results. In a snapshot, the Target BP recognition program includes, again, participation in Target BP, improvement in blood pressure control, which is a 10% improvement in blood pressure control rate over the baseline, or greater than 10% on blood pressure improvement measure, achievement in blood pressure control of a 70% control rate in one of 3 quality improvement areas, or an 80% blood pressure control rate and one of the 3 quality improvement measures. So next we'll review the MAP framework. Julie?
Okay, so the MAP framework, there we go, was created by the American Medical Association and Johns Hopkins, and there's 3 components to this framework. So the first one being measure blood pressure accurately every time it's measured. So proper measurement is critical to controlling blood pressure. Each practice should build a protocol to ensure accuracy of blood pressure readings. The second component is act rapidly to address high blood pressure readings. The MAP framework requires rapid action during a patient visit to address any problems. This step prioritizes follow-up appointments and a clear treatment plan to help patients achieve blood pressure control. The third component is partnering with patients, families, and communities to promote self-management. The power to change one's health begins in the healthcare office, but real change comes when patients take ownership of their health. Engaging your patients, their families, and communities helps promote sustainable lifestyle change, supporting the improvement of overall health. So, in going a little bit more detail of the MAP framework, there is a MAP checklist that's available on our Target BP website. So we're going to go in a little bit more detail about the first component. So why measuring blood pressure accurately? And also I want to mention that, as we go through the different components in this framework, on the Target BP website, under the provider resources, there's a fact sheet for every one of these areas. So there's a fact sheet on measuring blood pressure accurately. So uncertainty of patient's true BP is the leading cause for failure of a clinician to act on high blood pressure in the office. There's significant blood pressure variability in all patients. Poor measurement technique increases reliability of a patient's blood pressure, which can lead to poor clinical decisions, adversely affecting the health of the patient. So how does this impact clinicians in practice? So some common areas made during office BP measurements could be anything from having the wrong cuff size, putting the cuff placed over the clothing, improper positioning, no rest period, terminal digit preference, talking to the patient, rapid cuff deflation. Some errors on the patient end is, not checking with the patient if they have a full bladder, if they've had some caffeine prior to the visit, or a recent exercise, or a recent meal, or if they're distracted by talking, texting, or reading. Some systemic factors could be the location of the monitor device, noise, or in the workflow. So why use office blood pressure measurement? It's an opportunity to obtain blood pressure Technology has improved measurement reliability. They're seeing that there's less human error using automated machines versus getting a manual blood pressure measurement. Protocols improve reliability, reduce variability and errors, and can improve workflow efficiency. And also obtaining confirmatory measurements increase diagnostic accuracy and reduces misclassification of hypertension. So by reducing errors and increasing reliability of blood pressure measurement, clinicians are less likely to hesitate when initiating or escalating treatment, also known as clinical inertia. So here's a diagram of a correct patient position for blood pressure measurement, and this is one of the fact sheets handouts on our website. And then just to reiterate the common factors contributing to uncontrolled hypertension. So failing to initiate or escalate therapy during an office visit. So with that missed opportunity with the clinical inertia, this occurs 60 to 75% of cases. So treatment, that's whether there's no follow-up or the failure to escalate therapy. And then with the poor patient adherence to treatment plan, whether it's lifestyle changes or medication therapy plan, accounts for 15 to 25% of cases. So you can see that the clinical inertia impacts more cases than the patient non-adherence. So the second area of the MAP framework is the ACT rapidly. So we just want to reiterate the clinical inertia, failure to initiate treatment, failure to titrate to goal, failure to recommend follow-up. And on the patient end, medication side effects, failure to take medication, too many medications, cost of medications, and this is also one of the fact sheets on the website. You can see here also that low health literacy is a factor amongst patients. In the patient resources, the American Heart Association fact sheets, the Answers by Heart fact sheets, are written at a lower literacy level. I know that a lot of clinics have their own materials, but this might be something you want to take a look at if you're looking for a more materials written at a lower health literacy level. So from a health system standpoint, factors leading to clinical inertia could be lack of clinical guidelines, lack of care coordination, poor communication amongst office staff. I know that there is a move to have more patient-centered homes to improve outcomes. I know in Minnesota with healthcare homes, clinics that are certified have seen better outcomes compared to clinics that are not certified. So this is the standardized treatment protocol that was mentioned earlier. You can see that in patients with hypertension with systolic blood pressures greater than 150 millimeters of mercury, there's an increased risk of acute cardiovascular events or death can occur with delay in medication intensification and delays in follow-up appointments, which can significantly impact the risk. The algorithm is also a handout within the provider resources. Next, Stephanie will share why partnering with patients, families, and communities is critical to the success of the Target BP program.
So to support your Target BP implementation, we offer not only evidence-based algorithms and protocols, but evidence-based communication strategies as well. So doing this is critical to engage your patient in his or her own treatment if you expect patients to adhere to their therapy. So when clinicians use this type of evidence-based communication, which is essentially talking less and listening more, you often learn more important details that help determine a preferred treatment approach. And when patients use this type of communication, they're more engaged, they're more committed, and as a result, they're more likely to adhere to their treatment. Additionally, using these communication techniques doesn't lengthen the visit. It actually shortens them, making them more productive, especially if all staff are using them. So evidence-based communication strategies include having open-ended questions about adherence, including recent medication use, exploring the reasons for possible non-adherence, eliciting, really talking to a patient and trying to find out their views on options and priorities to help customize a care plan for each patient, remaining non-judgmental at all times, and using teachback to ensure that the patient understands what their care plan is. So this could be asking, whether or not a patient can afford their medications, if they're having any cost issues, if they're having transportation issues picking up their medication, if there are time constraints with their work scheduling, if they are, for example, supposed to take their medication in the morning, but perhaps they work a night shift and they may be sleeping through their medication time, really just asking the questions that are going to help develop the most productive treatment plan for the patient. And the key takeaways of that whole communication strategy is that the goal is to understand the patients, not to interrogate them, to encourage patients, not persuade them, and then to support patients and not necessarily fix them. So we have a great emphasis as well on self-monitoring blood pressure, and we feel that this is clinically useful for a variety of reasons, because it's going to reduce the variability and provide more reliable blood pressure measurements. It's going to provide a better assessment of hypertension control. It's going to empower patients to self-manage their own hypertension, and it may improve medication adherence among patients. So by empowering patients to self-manage, you're going to empower them to check their own blood pressure control and then report back on their results, make adjustments between visits, and to self-manage their hypertension. So if they are at home taking their own blood pressure every day between visits and they notice that their blood pressure is higher or that it's lower, that perhaps they're under some type of stress at work or something has happened, they will be able to, and they'll feel comfortable calling back into the office to communicate what's happening with their blood pressure measurements. So there are ways that you can use self-monitoring blood pressure in clinical practice, and that's going to include educating staff about how to train patients on the proper use of self-measurement and why it's critical. So that's going to include teaching them the proper measurement technique, telling them how frequently to measure their blood pressure and how to accurately record it, as well as the plan that you two have developed for controlling their blood pressure. Part of that plan will be how to act if their blood pressure is out of the desired range, and then how to communicate their readings to the clinical team. We also encourage lifestyle changes for hypertensive patients as part of Target BP, and that would include a healthy diet, such as the DASH diet, reduced sodium intake. The American Heart Association, as you probably know, recommends no more than 1,500 milligrams per day. Weight loss to that lower BMI below 25, aerobic exercise, moderate alcohol consumption, and no smoking, which can all equate to taking a pill to lower blood pressure. So the impact of lifestyle changes for improving blood pressure in patients with hypertension is significant. The DASH diet, for example, can lower blood pressure 11.6 or 5.3 milligrams. Reducing sodium intake also can have a significant effect on lowering blood pressure, as well as an average weight loss of 11 pounds or 40 minutes of moderate intense aerobic physical activity at least 3 to 4 times per week. And I will say that as someone who was clinically diagnosed with hypertension many, many years ago. My own physician's approach in doing this exact same thing made a lot of difference, also helped build confidence in my certainty that my physician really had my best interest at heart, particularly that she took a lifestyle approach before prescribing medication and the regular 3-month interval follow-ups. So doing all of these things, I have seen all of these things work on a personal and a very clinical level. So we have key messages that we suggest when advising patients about healthy lifestyle choices to lower blood pressure. And again, that's reducing the amount of salt in food and processed foods, eating at least 5 servings of fruits and vegetables per day, choosing whole grain products over refined grains, gradually building up to 40 minutes of physical activity most days of the week, limiting calories, and using personalized and cultural food preferences. And when you combine that with the self-monitoring that they are making these adjustments, the patient will most likely be able to see changes in their blood pressure in between visits as well, and so that is also motivational on the patient end. And so partnering with patients, families, and communities, we have provided you with a checklist. That would include helping patients accurately self-measure, directing patients and families to resources that support medication adherence and healthy lifestyles. We have tremendous resources at heart.org, and then engaging patients using evidence-based communication strategies. So we have our own self-monitoring program at the American Heart Association that we are recommending for patients. We are implementing that in a variety of settings, and that's our Check Change Control program, which is a community-level blood pressure monitoring program. It's proven to improve the blood pressure of people with high blood pressure. The average drop in systolic blood pressure of participants is 11 millimeters. Key evidence-based components for this self-monitoring program include self-monitoring outside of a healthcare setting. Blood pressure can be measured at home, at work, or in the community. And the self-monitoring has been shown to help participants reduce their blood pressure. So we have an online tool to assist patients who choose to use Check Change Control, in which they track their blood pressure readings and also provides a report to the organizer of the site that can provide feedback to those who participate. There is just a plethora of awareness and educational tools for participants of Check Change Control on topics such as high blood pressure, healthy eating, physical activity, and medication management. And this is basically a 4-month educational program, but patients can continue to use it outside those parameters as well. So earlier we shared the evidence-based tips for patient self-management of blood pressure during this presentation. So, I'm sorry, wrong slide. So I think, okay. So we have, again, sorry, I have to enlarge the slide, sorry. So evidence-based tips again include instructing patients to measure their blood pressure accurately using a validated automated device and correct positioning of measurement, asking the patient to record morning and afternoon blood pressure measurements for 4 consecutive days between office visits, and then developing a systematic approach to ensure that patients can act rapidly if their blood pressure is elevated between office visits, and then counsel patients that self-measured blood pressure is considered elevated. 135/85 is considered elevated. And so this is our self-monitoring solution, which includes, again, handouts, web-based instruction, emails that go out to patients through Check Change Control, targeted messaging, in addition to uploading their blood pressure readings. Okay,
Okay, next we are going to do a little bit of website demonstration. So if you can give us a minute to connect. Yep, so we'll walk through and show you where how you can sign up for the program, which Stephanie will talk about as well, and the different resources that we have on there, from the patient resources and the provider resources. Okay, can everyone, maybe I should say, Stephanie, can you see the website?
I'll pull it up on my end.
Okay. I think you should be able to see the website. So this is the Target BP website. The American Heart Association and American Medical Association has. You see, it was recently updated if you've gone here before. So you can pull up information here. If you want to learn more about the MAP framework, it's right here. Participant resources, the provider resources. So you can see these are all PDFs that you can access. Let's do an example here of if you wanted a diagram of measuring blood pressure accurately. Taking a while to load, sorry. Seven simple steps to get an accurate blood pressure reading. The diagram right there. Some of the different things that we mentioned, such as reducing clinical inertia. There's a fact sheet on that, and there's also podcast videos if you prefer that. The treatment algorithm that we talked about. Here you can pull up the brochure there. And then the communication strategies that Stephanie talked about in promoting lifestyle changes are all here as well. And then patient resources you can access here or on the main page. So I talked about the fact sheets written at a lower literacy level, so we can take a quick peek at one right here. So it's just, what is high blood pressure? Simple. And then every one of these fact sheets has a section where patients can write down their questions or, notes from their visit. The different resources. And then the recognition program. You can get more information here. There is some validation requirement through some aggregate data submission, but it's pretty minimal to get recognition. But as Stephanie mentioned, you can also get recognition by just participating in the program. And how to do that is you would register for the program. And I know Stephanie is going to talk more about that. Okay, now we're going to transition back to the presentation. Give us a minute.
Let me know when you're ready.
Okay, just need to advance a few slides. You can go ahead, Stephanie.
Okay, so we have our recognition timeline in front of you. And so this quarter we are looking at applications and data submissions. We're putting together our participant dashboard and our affiliate staff dashboard. In a couple of months, we'll have our data submission deadline for 2017 awards. And then in September, we will announce our awardees for participant improvement and achievement. The following tools and resources have been posted to the Target BP website that Susan just went through, and they can be accessed at any time. So again, those are podcasts, fast fact sheets, supporting materials, the basics of high blood pressure, treatment of high blood pressure, and then monitoring high blood pressure at home, a measurement log, proper positioning, all those pieces. And then how can you participate? Again, by registering at targetbp.org. Be sure to review the resources on the website to learn more about improving blood pressure management and control. We encourage you to share the information that you find on Target BP with your clinic or your healthcare system, and then make a commitment to improving blood pressure control in your clinic and community. And then, of course, there's the opportunity to get recognition for your practice's achievement in patient blood pressure control. We have local contacts available in Michigan. Stephanie Worth, I would be the contact in Michigan. In Minnesota, it is Sue Ling. And in Wisconsin, it is Tim. And we will be glad to assist you in your implementation efforts. So at this time, we're going to transition to the question and answer portion of today's webinar, but we want to thank the Lake Superior Quality Innovation Network for hosting us today.
Very good, thank you. We can now begin our question and answer session. If you have a question, please press *1 on your touch-tone phone. If you wish to be removed from the question queue, press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, press *1 on your phone.
And this is Jerry. I just wanted to take this time while we're waiting for people to queue up with their questions and thank both Stephanie and Sue Ling for the presentation today. It was very informative, and it looks like a very exciting program. And that they'll be able to participate in this Target BP program. Do we have any questions on the phone?
No, I'm afraid we have no questions.
And also, I don't see any questions in chat right now, but if you prefer to put your questions in chat, that is also fine for any of the participants.
So this is Sue Ling. I just want to add to that no matter where you're at with your program within your clinic or site, I think Target BP probably has a little bit of something for everyone, whether you're a clinic that's got great clinical outcomes, the recognition program may be something of interest to you, or if you're a clinic that, might be on the bubble, having 50 to 70% control. Some of these resources might be of interest to you, but we encourage you to register no matter where you are within your program, because you'll get updates on some of the webinars and opportunities for continuing education, as well as updates, if there is any updates to any of the clinical guidelines.
I was just going to ask you quickly, Sue Ling, do you know, or Stephanie, do you know how many clinics or physician offices have already signed up to be part of the program? It started in 2015, right? So I was just wondering, and maybe you said that, and it went over my head.
I did not, but we can certainly find out.
Okay.
I don't know if Stephanie, you know.
I don't know offhand. No, I was going to try and look real quick.
And again, James, do you just want to remind it again how to ask a question for the phone line?
Sure thing. If you have a question, press *1 on your phone. And we have no questions over the phone.
Thank you, James. Since we don't have any questions, I just wanted to let everybody know if you do have a question, you think of something after the fact, certainly you can reach out to your American Heart Association contacts in each of your states, or you can also reach out to your local, your state quality improvement organization that's part of the Lake Superior Quinn. This presentation will be posted to the Lake Superior Quinn website so that you can also watch it. I just wanted to remind everybody, as you sign out, an evaluation will pop up, and we'd really like for you to fill that out. It helps us determine our upcoming presentation, so take the time to fill that out. Since there are no questions, we're going to give you those extra 10-15 minutes back. Thank you again, everyone, for joining us, and have a great rest of the day.
Thank you.
Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.